Welcome to Module 8, Thought Disorders. We will focus on schizophrenia, schizoaffective disorder, brief psychotic disorder, and delusional disorders. We also discuss the nursing interventions for such disorders and the client outcomes. We'll also go over some medications used to treat thought disorders and their common side effects. As usual, download your study guide and the PowerPoint. Let's dive into it. What is schizophrenia? Schizophrenia means a split mind or a disconnected mind from reality. The term schizophrenia was coined in 1908 by Eugen Bleuler, a Swiss psychiatrist. The disconnection may be due to neurodevelopmental abnormalities or biochemical imbalances, such as an increase in dopamine neurotransmitter. Other causative factors of schizophrenia spectrum disorders may include genetic predisposition, physiological factors, and psychosocial stress. However, remember in nursing, we focus on the transactional model, which considers the interaction between genetic, biological, and psychosocial determinants. Please note that there is no single treatment that has proven to be effective for schizophrenia spectrum disorders. The common onset for schizophrenia is in the early 20s, and clinicians agree that the treatment requires both medications and therapy to be effective. While there is no cure for schizophrenia, clients can learn living and social skills to become productive members of society. Some of the predisposing factors for schizophrenia include genetics, which plays up to 10% risk, especially for the siblings of a client with schizophrenia. We discussed biochemical imbalances, especially the excess dopamine activity in the brain, being one of the common predisposing factors. The MRI results in clients with schizophrenia also showed a reduction in symmetry of several brain lobes and structures in the limbic system. Other predisposing factors include poverty. However, poverty is usually viewed as a contributor and not necessarily a cause of schizophrenia. Also, stressful life events can lead to the severity of schizophrenia, though there is no scientific evidence that stress alone can cause schizophrenia. Some studies have shown that smoking weed, especially for teenagers, can result in developing schizophrenia. Cannabis can induce schizophrenia-like symptoms and also make psychosis worse in clients who already have schizophrenia. Remember, there is no single theory that provided a satisfactory or clear-cut explanation of schizophrenia causes. So, in nursing, we continue to refer to the transactional model, which considers the interaction between genetic, biological, and psychosocial predisposing factors. What is psychosis? Recall the definition of psychosis. Psychosis can happen in delirium, acute mania, schizophrenia, and many other conditions. Psychosis entails a disorganization of personality, and clients appear to have lost contact or have a distorted view of reality. For example, clients with visual hallucinations or delusions often experience psychosis. Earlier in this module, we discussed training clients with schizophrenia in life and social skills for them to become productive members of society. Why do we do this? Because these clients experience severe deterioration of social and occupational functioning, especially during late adolescence and early childhood. Hallucinations or psychosis cause detachment from reality. They negatively affect their thought processes and perception. Therefore, it is important to use a multidisciplinary approach to redirect them to reality and ensure they can still perform their activities of daily living. Let's look at the different phases of schizophrenia. The pattern of development of schizophrenia may be viewed in 4 phases: the premorbid phase, the prodromal phase, the active psychotic phase, schizophrenia, and the residual phase. We will discuss each of them in the next slides. In the premorbid phase, there is usually no clear evidence of schizophrenia. Some clients may appear shy or antisocial. Recall the movie we watched together, named Of Two Minds. Baby, also known as Elizabeth, was shy and antisocial in the beginning of the movie before she developed hallucinations or even catatonic features. Premorbid signs are those that occur before there is clear evidence of illness and may include distinctive personality traits or behaviors. In the second phase, which is a prodromal phase, we start noticing changes in personality and behaviors. Most clients present with social withdrawal symptoms, deterioration in social functioning, and mistrust of other people. At least half the clients develop depressive symptoms. These are clear symptoms of developing schizophrenia. Clients are just not only shy or antisocial but also develop psychotic symptoms. The average length of the prodromal phase is between 2 and 5 years. Some adolescents may also develop OCD. The third phase is an active psychotic phase, in which psychotic symptoms are obviously prominent. Some of those symptoms include hallucinations and delusions, speech changes, such as disorganized speech, and inability to perform activities of daily living. Clients have a hard time keeping their jobs, are unable to remain in social or personal relationships, and even neglect their own hygiene or sleeping needs. Let's discuss the positive symptoms of psychotic disorders. The easiest way to differentiate positive from negative symptoms in clients with schizophrenia is that positive symptoms are manifestations that are not normally present or distortion of normal function, whereas negative symptoms are the absence or diminution of normal behaviors or things that are normally present. Clients can also present with positive and negative symptoms, also known as mixed symptoms. The most common positive symptoms include delusions, also known as false personal beliefs, such as paranoid delusions, which describe the extreme suspiciousness of others and of their actions or perceived intentions. They also include delusions of reference. Events within the environment are referred by the person to himself or herself. For example, someone is trying to get a message to me through the articles in this magazine, or newspaper or TV program. And delusions of control or influence. The individual believes certain objects or persons have control over his or her behavior. Other positive symptoms entail paranoia, or being extremely suspicious of other people, and magical thinking. Magical thinking implies that people can use their thoughts to control the environment or circumstances. We will discuss later additional positive symptoms, such as hallucinations and alterations in speech. Negative symptoms imply the absence or lack of what is usually present. Compared to positive symptoms, negative symptoms are harder to treat. The common negative symptoms include the effect, expression of emotional reaction, which may be flat or blunted, which means their expressions do not show outwardly. They include alogia or poverty of speech, which is a lack of conversation or how to express their thoughts. They may lack energy, inertia, and lack motivation for self-care, avolition. They may also present with waxy flexibility in which their body parts are placed in a bizarre posture for a long time. It really appears very uncomfortable to other people. You also noticed some clients who keep pacing on the floor a long time at clinical sites. Pacing back and forth and rocking consist of negative symptoms of schizophrenia. Negative symptoms of schizophrenia sometimes reflect socially unacceptable behaviors. Some of the most common cognitive symptoms you may notice in clients with psychotic disorders include the impaired thought process, especially for short-term memory, decision-making, impaired sensory perceptions, impaired verbal communication, self-care deficit, and difficulty with concentration. Social isolation, inability to make decisions, and poor problem-solving ability. So, let's now talk about the affective symptoms usually seen in schizoaffective disorder. It is similar to schizophrenia, but clients with schizoaffective disorder also present with hopelessness, unstable or rapidly changing mood, and mania. We will discuss schizoaffective disorder in the following slides. One of the most common positive cognitive symptoms we went over earlier consists of alterations in perception. Most clients diagnosed with schizophrenia present with hallucinations and delusions. You will notice auditory and visual hallucinations are discussed quite often, but keep in mind that hallucinations are false perceptions that may involve any of the five senses. Auditory hallucinations entail voices that clients may report that they hear in form of music, clicks or rushing noises. Please note that we should be careful if clients report command hallucinations that usually tell them to harm themselves or others. These voices should be prioritized. Visual hallucinations consist of seeing formed images like people or unformed images, flashes of light. Tactile hallucinations involve the sense of touch. Clients usually report something on or under the skin like, there is a snake crawling on my arm. Gustatory hallucinations involve taste. For example, they may report unusual tastes for common foods or drinks. Olfactory hallucinations entail a sense of that is, of course, different from what other people would smell in the same environment. Clients with schizophrenia have difficulty with personal boundaries. They often have detachment from self, mind, and body, also known as depersonalization. They report feeling like an observer of their own body. They sometimes also feel detached from the environment or perceive a change in the environment or objects around them that others do not perceive. The world around them may appear distorted. For example, they may report South Mountain as a flat surface. It is very important to differentiate illusions from delusions. Illusions are simply perceptual disturbances or misinterpretations of external stimuli like optical illusions or moon illusions. Remember, people can have different interpretations of the moon depending on the angle at which they look. On the other hand, delusions are misconceptions of reality. Echopraxia is simply imitating other people's movements and also happens in schizophrenia. Current evidence suggests that it may involve a disturbance in mirror neuron activity. We already discussed 3 phases of schizophrenia, which consist of premorbid, prodromal, and active psychotic phases. Good job if you were able to recall them. The 4th phase is the residual phase. This is a period of remission, which usually follows an active psychotic phase. Positive symptoms, like delusions and hallucinations, may be improved, but negative symptoms like flat affect and inertia may remain. Residual impairment often increases between episodes of active psychosis. Remember, there is no cure for schizophrenia. So, a return to premorbid functioning in clients with schizophrenia is not really common. A delusional disorder differs from schizophrenia as it consists of the presence of delusions experienced for at least 1 month. Hallucinations are not prominent, or may not be present, and behavior is not bizarre. Clients do not necessarily experience impairment in interpersonal or self-functioning. Please familiarize yourself with its subtypes, such as erratic, grandiose, jealous, persecutory, somatic, and mixed-type delusions. The most common types are grandiose delusions in which clients have irrational ideas of being all-powerful, exaggerating their self-worth and knowledge. Persecutory delusions occur when clients have irrational ideas or feelings of paranoia, which become a more fixed belief. Or, they report being plotted against, like some people are trying to poison them, want them dead, or the CIA, FBI, MI5, and many other secret intelligence service entities are spying on them. As for brief psychotic disorder, please note that its symptoms happen abruptly and usually last for at least 1 day but less than 1 month. Clients may have previously experienced a psychosocial stressor or not. There is an eventual full return to a normal level of functioning. Clients may also have incoherent speech, delusions, hallucinations, bizarre behavior, and disorientation, and even catatonic features. Similar to our discussion of bipolar disorder causes last week, it is also likewise crucial to rule out whether psychotic disorder symptoms such as hallucinations and delusions are associated with substance intoxication, withdrawal, or exposure to a medication or toxin as the contributing factors. Some drugs that may lead to psychosis include alcohol, amphetamines, cannabis, cocaine, and opioids. Medications may include anxiolytics, anticonvulsants, antimicrobial medications, disulfiram, muscle relaxants, and the toxins may include nerve gases, insecticides, carbon dioxide, and gasoline. We already mentioned catatonic features in schizophrenia. Catatonia refers to a significant motor disturbance that may range from stupor, or no motor activity to excessive motor activity and agitation, which is part of negative symptoms. The disorders in which catatonia may appear include brief psychotic disorder, schizophreniform disorder, schizophrenia, schizoaffective disorder, and substance-induced psychotic disorder. Common symptoms: stupor, catalepsy or muscle rigidity, waxy flexibility or remaining in one bizarre position for a long time, mutism or inability to speak, and negativism are present. Please also note that catatonia may happen with metabolic disorders, such as hepatic encephalopathy, thyroidism, vitamin B12 deficiency, etc. The most important aspect of schizophreniform disorder to remember is the duration, which is between 1 and 6 months. Clients with schizophreniform go through similar phases, including prodromal, active, and residual phases, as schizophrenia. Usually, if clients have psychotic symptoms for less than 6 months, their diagnosis is provisional. Psychiatrists and the interdisciplinary team monitor such symptoms. After 6 months, they can receive a definite diagnosis of schizophrenia. We already discussed schizoaffective disorder earlier on slide 16, as it is characterized by affective symptoms, including either depressive symptoms or mania. Alterations in thought processes manifested in speech are the positive symptoms of schizophrenia. The most common ones include loose associations, characterized by speech in which ideas shift from one unrelated subject to another, and the individual is unaware that the topics are unconnected. For example, I like to dance. My feet are wet. When the condition is severe, speech may be incoherent. Clang associations consists of the choice of words governed by sounds, often take the form of rhyming. For example, I tied the rope soap the slope nope. It is very cold. I am cold and bold. The gold has been sold. Word salads consist of putting together in a random fashion. For example, trees screamed broken glass. For perseveration, the individual who exhibits perseveration persistently repeats the same word or idea in response to different questions. It is the manifestation of a thought processing disturbance in which the person gets stuck on a particular thought. Echolalia refers to repeating words or phrases spoken by another. In toddlers, this repetition is a phase in development, but in children with autism, echolalia may persist beyond the toddler years. Tangentiality refers to a veering away from the topic of discussion and demonstrates the difficulty in maintaining focus and attention. Neologisms are newly invented words that an individual invents that are meaningless to others but have symbolic meaning to the client who has psychotic disorder. For example, clipno for watch. She wanted to give me a ride in her new uniform. Can you give more examples of neologisms? Now that you have a firm grasp of thought disorders, let's discuss some nursing interventions for these clients. What are the nursing interventions for a client experiencing visual or auditory hallucinations? Safety is a priority. Remember, if they are experiencing command hallucinations, we should prioritize safety. Therefore, determining their suicide or homicide should be prioritized. We do not question the hallucinations, for example, why the voices are only talking to you. However, we can inquire whether the voices are telling the client to harm themselves or others. We can distract them or divert their attention from command and other hallucinations by reinforcing or redirecting them to reality. We can recommend that they go to therapy if they are stable. This is, for example, if they are not experiencing psychosis, or they have been taking and are compliant with their medications for a long time. The positive outcomes we anticipate for clients with psychotic disorders include, but not limited to, making sure they do not harm themselves or others, they are aware of distortions of reality and change their perception of self and reality by being realistic. We also want them to manage their anxiety to the lowest level possible, take care of their activities of daily living and communicate with others appropriately. The recovery model is used in clinical settings and involves a multidisciplinary team approach. We want to ensure that clients with schizophrenia do not only comply with medications, but also learn and apply life and social skills to remain functional and productive members of society despite having a serious mental illness. It is exciting to know that your favorite aspect of mental health nursing is psychotherapy. We use antipsychotics, also known as neuroleptics, such as haloperidol and loxapine, to treat positive psychotic symptoms. Please keep in mind that antipsychotics take several weeks, usually 2 to 6 weeks, to effectively treat positive symptoms. Basically, we start seeing improvement within the first 2 weeks, but we usually wait till at least 6 weeks to determine whether the drug has reached the full therapeutic effect. Please recall that the side effects of first-generation antipsychotics include extrapyramidal or EPS symptoms, which include pseudoparkinsonism, akinesia, akathisia, dystonia, and oculogeric crisis. We already discussed each EPS symptom in Module 3. Please ensure you refamiliarize yourself with them. EPS symptoms can be treated by antiparkinsonian agents. Such medications may include anticholinergics, such as benztropine or trihexyphenidyl, antihistamines, such as diphenhydramine, or benzodiazepines, such as lorazepam or diazepam. Recall AIMS or Abnormal Involuntary Movement Scale, which helps in early detection of movement disorders, especially tardive dyskinesia, and provides means for ongoing monitoring. Tardive dyskinesia is an EPS that involves bizarre face and tongue movements, stiff neck, and difficulty swallowing. It may occur with all classifications but most commonly takes place with typical antipsychotics. The second generation or atypical antipsychotics, such as risperidone, olanzapine, ziprasidone, and clozapine, have become the first line of treatment for clients with schizophrenia. Such drugs may also be effective for treating negative symptoms of schizophrenia and alleviating positive symptoms such as hallucinations, delusions, and agitation, which makes them in the first generation. We cannot stress enough the need to monitor clients who take clozapine for symptoms of agranulocytosis it induces, such as sore throat, fever, or malaise, because they are at risk for infection due to neutropenia, extremely low levels of absolute neutrophil count or ANC. Also, metabolic syndrome is a side effect to watch for in clients taking atypical antipsychotics. Be able to remember the common side effects of antipsychotics, including but not limited to sedation, nausea, EKG changes, drooling, weight gain, EPS, agranulocytosis, tardive dyskinesia, and NMS. Aripiprazole is an atypical antipsychotic. Aripiprazole, also known as Abilify, an atypical antipsychotic, was more recently introduced as a third-generation antipsychotic. It was approved by the FDA to treat schizophrenia in November 2002. It treats both positive and negative symptoms. It has lower risks for EPS symptoms and weight gain. Congratulations, give yourself a pat on the back for reviewing all the slides till the end.